Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Stand Medical Notes and Lecture. So this will be the last video of the topic of diabetes mellitus. Okay, let's begin with the name of Almighty. So we have discussed the treatment of type 2 diabetes mellitus with oral hypoglycemic drugs as well as insulin therapy, and we have also discussed the treatment of type 1 diabetes mellitus with advanced insulin therapy along with case scenarios. So then comes how will you monitor and follow up a patient of diabetes mellitus. So here is the guide. The follow up should be individualized. Intervals should be tailored to patient stability and risk level. So depending upon the 2024 guidelines. At every visit, you should inspect the foot of the patient. So check for any lesions or ulcers, especially in high risk patients. So high risk patients mean those who are having neuropathy, okay, meaning they have lost their sensations in their foot. Okay, so mainly you should check pulses, pulses of dorsalis pedis, pulses of posterior tibial artery, and for high risk patient, meaning you should perform the 10-gram monofilament test, 10-gram monofilament test, or else you can also perform a test with tuning fork. So the first and foremost sensation which is lost in type 2 diabetes mellitus is vibratory sensation, so that you can test. So these two things you should do at every visit in foot. You check for lesions, and you check for pulses, and you check for neuropathy. Every 3 months you should measure HbA1c of the patient. Okay, and if the patient is stable, you can check it at every 6 months, meaning if the HbA1c is in the target, then you can check it every 6 months. And every 3 months, if you change the therapy of the patient, or if HbA1c is not at the target, then you should check it every 3 months. So two conditions you check it at 3 months, that is when you change therapy and when A1C is not in target. But if the patient is consistently stable and the HbA1c is in target, then you can check it every 6 months. So that is one thing. And BP you should measure every 3 months, and weight you should measure every 3 months. So these blood pressure and weight are nothing but routine monitoring of cardiometabolic targets. Okay, annually, yearly, what you should do? So yearly you should measure the lipid profile. So this gives you a measure of vasculopathy, macro what do you call, large vessel, macrovasculopathy, you can say macrovasculopathy. Okay, so lipid profile. Okay, and it will help to guide statin therapy. And these three, kidney, eyes and foot, these you will give a measure of microvasculopathy, nothing but microangiopathy. This is macroangiopathy. So this will give a clue to cardiovascular risk. This will give a clue to microvasculopathy. So here it is nephropathy, retinopathy and diabetic foot. So every year you should check lipid profile, urine albumin creatinine ratio and estimated glomerular filtration rate to rule out diabetic kidney disease. Okay, and eye examination to monitor for progression of retinopathy. So this is done ideally by an ophthalmologist. Foot examination to monitor for progression of neuropathy. So this is annually 4 things: lipid profile, USCR, EGFR, eye examination and foot examination. And if some patient is using this continuous glucose monitoring, then this should be this actually continuously only. So the patient should see time in range and time below range. So the target time in range is more than 70% in the target, and time below range is less than 1%, 1 to 4%. Okay, that is about the 2026 guidelines. And 2026 guidelines recommend continuous glucose monitoring for those on insulin or non-insulin therapies where it aids management. Okay, so that's about the monitoring of diabetes mellitus. Okay, so by this, some special contexts in diabetes mellitus. So patient who are using steroid, there is, as we all know, that steroid cause hyperglycemia. So what they do, they will increase the insulin resistance, they impair the beta cell secretion, and they cause massive hepatogluconeogenesis. And that's why steroid patients have a postprandial increased blood sugar level. Postprandial increased blood sugar level, but remember, fasting blood sugar level will be normal. It can be normal in steroid patients, so that is a big pitfall. So if a patient is on steroid, just seeing fasting blood sugar level and not adjusting the dose of drugs or insulin is a very major pitfall, because steroids increase the postprandial blood sugar level. Okay, see here the same thing I am saying, no? So clinical pitfall is this one. So normal fasting blood sugar level deceives the clinician, because steroids cause abrupt massive hyperglycemic surge after food. After food. Okay, that's why the targeted solution is co-administered NPH insulin with morning steroid dose. Okay, so that is the solution. Co-administer NPH insulin with morning steroid dose. So this is the insulin and this is the glucose surge after steroid. Usually the steroids are given in the morning. Okay. Now one thing to remember is aggressive down titration required upon tapering steroids to prevent iatrogenic hypoglycemia. Yes. So if some patient who is on chronic steroid therapy and he is given insulin NPH to counter this postprandial spike of glucose, and suddenly the patient is stopped on steroids, and but his insulin is not stopped, then that will cause iatrogenic hypoglycemia. That should be kept in mind. So when you are tapering steroids, you should decrease the dose of insulin or hypoglycemic drugs. So that is one thing. Okay, that is one special context. The second special context is, so the sick day rules, this should be remembered. Sick day rules, what happens when the patient is sick, for example in intercurrent illness or infection or trauma, there is massive surge of counter regulatory stress hormones like cortisol, catecholamines, okay, and glucagon. Cortisol, glucagon, catecholamines, all they increase the insulin resistance, and the patients are at risk of diabetic ketoacidosis and HHS decay in type 1 and HHS in type 2. Okay, so sick day rule number 1, alert for type 1 diabetes patient is, this is also known as 6-day rule #1. So never stop basal insulin. This is very important point. Never stop basal insulin even if the patient is not taking food. Okay, for example, patient is having gastroenteritis, vomiting, can't eat, patient will think I will not take insulin, I don't need insulin. So that is a dangerous thing. Okay, that is a dangerous thing that can precipitate the diabetic ketoacidosis if the patient stops basal insulin. Okay, why? Because stress of illness increases the basal requirement of insulin. That's why sudden withdrawal quickly precipitates diabetic ketoacidosis. That's why this is a very important thing which a type 1 diabetes patient mellitus should be inquired. Third, so in the sick day rules, there is something known as SADMANS protocol. So temporary pause these SADMANS drugs. Actually, SADMANS is a mnemonic for drugs which should be stopped during acute illness and dehydration. Okay, so S for sulfonylureas, because they can cause extreme hyperglycemia if oral intake is reduced. A for AC inhibitors, D for diuretics, M for metformin, A for ARBs, N for NSAIDs, S for SGLT2 inhibitors. So sulfonylureas can cause hypoglycemia, ACE inhibitors can cause acute kidney injury, diuretics can cause volume depletion, hypotension, metformin can cause MALA. What is MALA? Metformin associated lactic acidosis. Okay. Again, ARBs can cause AKI, NSAIDs can also cause AKI, SGLT2 inhibitors can cause the dehydration and euglycemic diabetic ketoacidosis. So pause these medications, contact the provider. One thing is wanted, patient should be informed to take a lot of fluids during sick day. Both patients of type 1 diabetes mellitus and type 2 diabetes mellitus, they should take a lot of oral fluids, and they should check they should check this blood glucose or urinary ketones frequently until the acute phase is resolved. So these are known as sick day rules. They should have a low carbohydrate but high food diet, high fluid diet. They should have a high intake of fluids, and type 1 diabetes patient should not stop basal insulin, and type 2 diabetes mellitus patient should stop SADMANS drugs during the acute stage. Coming to the third special context, that is perioperative and inpatient management. So patient who are going for surgery and patient who are admitted in the clinic, the hospital. So patient who are admitted, so for surgery or for critical illness, remember, for surgery or for critical illness, continue all the oral anti-hyperglycemic agents because they are at risk of hypoglycemia. So patients who are admitted for surgery and critical illness should discontinue all the oral anti-hypoglycemic agents because they are at risk of hypoglycemia. So they should be started on insulin. What should be done then? They should be started on insulin. Okay. So insulin therapy IV, mandatory in ICU and for prolonged major surgery. So the protocol which is followed is known as variable rate intravenous insulin infusion. Variable rate intravenous insulin infusion, VRII. So continuous IV regular insulin is given, and the target glucose range is kept at 140 to 180 milligram per deciliter. Avoid aggressive normalization, meaning don't allow the blood glucose levels during this acute phase to fall less than 110 milligram per deciliter because it increases the mortality and there can be severe unrecognized hypoglycemic events. Now once the acute phase resolves, one thing to remember is should not how to transit the patient from IV to subcutaneous insulin. Okay, so the golden thing, the important point to remember is discontinue administer subcutaneous basal insulin at least 1 to 2 hours prior to terminating IV insulin. So this is an important point. So while you are transiting from IV to subcutaneous, when the surgery is over or when the acute illness, when the patient is shifted from ICU to general ward, so when you are shifting to subcutaneous insulin, then first you should start the subcutaneous insulin, even though the patient is on IV insulin, 1 to 2 hours before you stop the IV insulin. Why? Because if you discontinue IV drip abruptly before subcutaneous basal insulin is given, there can be rapid rebound diabetic ketoacidosis because IV insulin has a very short half-life. So patient can develop DKA in minutes. That's why always give subcutaneous insulin 2 hours before discontinuing IV insulin. So that is one thing one should remember. And one more thing is standalone reactive sliding scale should not be used. It is very dangerous in patients who are critical. Okay, proactive basal bolus or basal plus regimens should be given. Same what these things mean? These things mean the same which we have discussed now. So sliding scale is nothing but you will give insulin whenever the patient has increased glucose level. So that is reactive insulin therapy, meaning you give insulin only when the patient has increased sugar levels. If the patient does not have, you will not give insulin therapy. So that is sliding scale. So that is absolute, this is outdated and it is dangerous. So you give proactive, meaning basal bolus or basal plus regimens patient who are requiring inpatient therapy. Okay, so that is an important thing. Don't give reactive. So you stop the oral hypoglycemic drugs and you start insulin patient who are in critical care or ongoing surgery. That is a important thing to remember. Fourth is oncology and immunotherapy induced diabetes. So drugs which are used in immunotherapy like immune checkpoint inhibitors and PI3K and mTOR inhibitors. So PI3K is a pathway where the cell uh, accumulates and produces energy, like that is nothing but glucose for the differentiation of the cells. So some drugs which are used in oncology and immunotherapy, so they use these two types of drugs, immune checkpoint inhibitors and PI3K. So immune checkpoint inhibitors, what they will do, they will rapidly, they can cause fulminant autoimmune destruction of beta cells, and that will cause ultra rapid onset of type 1 diabetes mellitus and diabetic ketoacidosis. So immediate recognition is required, and these patients who develop this autoimmune diabetes mellitus due to the use of immune checkpoint inhibitors, they should receive lifelong insulin therapy. So this point should be kept in mind whenever a patient is receiving immune checkpoint inhibitor. So PI3K and mTOR inhibitors, so they will cause extreme peripheral insulin resistance, and they cause type 2 type of diabetes mellitus. Okay, so ADA designates metformin as preferred first line drug those who develop type 2 type of diabetes mellitus due to the use of PI3K and mTOR inhibitors. So that is the fourth special context. Now coming to the fifth special context, that is last special concept. So there is a misuse of cannabis. You always everybody know that. So cannabis misuse. So recreational cannabis use can cause something known as cannabis hyperemesis syndrome. Okay, and this can be misleading. This can be misleading because diabetes patient, if they are using cannabis for recreational purpose, then the symptoms of diabetic ketoacidosis and symptoms of cannabis hyperemesis syndrome are similar. That's why clinicians may recognize late. There can be delay in recognizing diabetic ketoacidosis, and patient may end up with diabetic ketoacidosis. So that is the thing. So cannabis hyperemesis syndrome, patient will have intractable cyclical vomiting, severe dehydration. Okay, so because of that, this profoundly complicates glycemic management, rapidly mimics diabetic ketoacidosis. Okay, and it can precipitate true or even severe ketoacidotic or hyperosmolar crisis because of extreme fluid and electrolyte loss. So the patient is losing a lot of fluids, and we are thinking that it is because of cannabis, but patient can develop even DK and HHS because of this. So that point should be remembered, and patient with diabetes mellitus should be counseled for this, that they should not use cannabis. They should not use cannabis because they are because the symptoms mimic, and they will have a high chance of developing DK and HHS. So these are all of 5 special contexts. So steroids, they cause PPVS and how to control that, and sick day rules, and perioperative and inpatient, how to manage these patients during surgery or critical care, oncology and immunotherapy induced diabetes, and cannabis hyperemesis syndrome. Last thing which we need to discuss is a case scenario of gestational type 2 diabetes mellitus. So after discussion of this gestational diabetes mellitus case scenario, so we will be completing the topic of diabetes mellitus. So next thing will be acute and chronic complications of diabetes mellitus. We will discuss it later in the coming videos. So here is a case. Here is a lady named here is a pregnant woman, 32-year-old female, gravida 2 and para 1. Okay, 24 weeks of gestation. That means she is in second trimester. Pre-pregnancy BMI was 29. There is a family history of type 2 diabetes mellitus. Patient is asymptomatic as of now. So she is in second trimester. She has risk factors for developing type 2 diabetes. That is, she is obese before pregnancy and she has a family history of type 2 diabetes mellitus. So she should be screened for type 2 diabetes mellitus. Okay, all pregnant women, so this is an important point, all pregnant women without known diabetes should be screened at 24 to 28 weeks of gestation. Just remember, at second trimester of pregnancy, all pregnant women should be screened for type 2 diabetes mellitus, particularly at 24 to 28 weeks. So those who develop gestational diabetes mellitus, the definition is those who develop diabetes similar to thyroid, those who develop diabetes mellitus at second trimester, they are only considered as GDM, as having GDM. Those who are having in the first trimester, they are not considered GDM, they are considered, they are previously diabetes mellitus patient. Okay, so development during second trimester is important. So let's discuss this case. So this lady was screened and at 24 to 48 weeks, and she was diagnosed with diabetes mellitus gestational. So remember, ADA recommends, okay, and IAD PSG criteria diabetes for diabetes mellitus in pregnancy is the gold standard is oral glucose tolerance test. So you should say the patient should fast at least 8 hours. She should not take any food for 8 hours overnight. Then in the morning she is given 75 grams of oral glucose. Then the values are measured, first fasting, then at 1 hour, then at 2 hour. Okay, OGTT. Fasting, her levels were more than, so diagnostic thresholds for confirming a case for gestational diabetes mellitus is any one abnormal value confirms the diagnosis of GDM. Fasting more than 92 confirms. 1 hour more than 180 confirms. 2 hour more than 153 confirms. Okay. Fasting more than 92. 1 hour more than 180. 2 hour more than 153. In her case, fasting was more than 92. See here it is 98. 1 hour is less than 180. Okay, normal. 2 hour is more than 153. See, it is 160. So two things are abnormal. So GDM is confirmed in this case. Now, initial non-pharmacologic management, weeks 24 to 26. Medical nutrition therapy. 30 carbohydrates, 33 to 40% of daily she should be counseled to take 40% of diet should be carbohydrates, and distribute this 40% of carbohydrates across 3 main meals, okay, and 2 to 3 snacks to prevent postprandial spikes and starvation ketosis. Okay, so what should be the glycemic targets? So glucose monitoring should be 4 times the glucose should be measured 4 times daily. Fasting 1 hour postprandial and 2 hour postprandial. So fasting the target is fasting should be less than 95. 1 hour should be less than 140. 2 hours should be less than 120. Lifestyle monitoring, regular physical activity, 30 minutes per day as tolerated. Weight gain per IOM guidelines. Self-monitoring of blood glucose 4 times daily, 1 fasting plus 3 postprandial. 3 postprandial. Okay, and review the logs in 1 to 2 weeks. Now pharmacotherapy initiation in week 26. Drug selection, first line drug is insulin because insulin does not cross the placenta and provides the most precise glycemic control. Alternative is metformin. It crosses the placenta, acceptable if patient refuses insulin or lacks resources. So weight and trimester based insulin calculation. So first trimester insulin requirement is 0.7 to 0.8 units per kg per day. Second trimester it is 0.8 to 1 units per kg per day. 0.7 to 0.8, then 0.8 to 1. Then third is 0.9 to 1.2. Okay, 0.9 to 1.2. First trimester 0.7 to 0.8. Second trimester 0.8 to 1. Third trimester 0.9 to 1.2 units per kg per day is the dose. Now in this paint, the weight of the patient is 80 kg, gestation is 26 weeks, that means second trimester. So 0.8 to 1 is the unit per kg is the dose of. So total day dose using 0.8 unit per kg. So we are starting at lower side. So 0.8 into 80 is 64 units per day. Now we have learned now this one. So basal insulin should be 50% and 50% should be before food. So it is 30 units. So 60 units should be given in the night and 60 units should be distributed among the 3 meals. So how you will distribute? Prandial 32 units, for example, like rapid acting Lispro and Aspart, 10 units before breakfast, 11 units before lunch, 11 units before dinner. So 10 plus 11 plus 11 is 32. Now titration and adjustment, weeks 26 to delivery. Rule of targeting: fix the specific insulin that dictates the abdominal reading. Here the rule is, so fix the abdominal reading. Adjust the doses by 10 to 20%, usually 2 to 4 units at a time. So fasting glucose was more than 95 milligram per cell. So increase, in this case, increase the bedtime baseline by 2 units. High post breakfast glucose at 1 hour. Okay. So increase the pre-breakfast prandial by 2 units. High pre-dinner glucose levels. So that is more than 120 milligram per deciliter. So increase the morning basal or pre-lunch prandial dose by 2 units. Okay. If insulin requirements suddenly and precipitately drop in the late third trimester, rule out placental insufficiency. This is one point. If insulin requirements suddenly and precipitously drop in the late third trimester, rule out placental insufficiency. Now intrapartum and postpartum follow-up. So during labor and delivery, maternal hyperglycemia during labor causes fetal hyperinsulinemia, leading to severe neonatal hypoglycemia after birth. That's why during labor or delivery, the target should be 70 to 110 milligram per deciliter. Now, because it is a critical time, you should use IV regular insulin infusion. Okay, 70 to 110. If there is hyperglycemia during labor, then because of fetal hyperinsulinemia, the delivered baby can have hypoglycemia after labor. So immediately postpartum, during day 0, discontinue all GDM specific insulin immediately upon delivering of the placenta. The source of insulin resistance, that is human placenta, is gone. So monitor fasting and postprandial glucose for 24 to 40 hours to ensure resolution, meaning for 2 days. So that is immediately after postpartum. So during labor, then immediate postpartum, then postpartum care, first 6 weeks. Breastfeeding should be encouraged. Healthy diet and physical activity. Assess for postpartum depression and provide support. Long-term follow-up from 1 to 3 months. 1 to 3 months. Okay. Up to 50% of women with GDM will develop type 2 diabetes within 10 years. So mandatory test, 75 gram of 2-hour OGT at 4 to 12 weeks postpartum should be done. Okay, meaning once in between 1 to 3 months should be done. Use standard non-pregnant diagnostic criteria. Okay, so similar to thyroid, those who have developed thyroid in pregnancy, they will have a future high risk of developing thyroid. So they also should be monitored. Similarly, these should be monitored, and at least one time in postpartum 1 to 3 months, they should have this OGT done. Future prevention: annual screening for diabetes every year. Maintain healthy weight and lifestyle. Healthy diet, regular exercise, adequate sleep. Okay. So some year of key targets: fasting should be less than 95, 1 hour should be less than 180. 140, 2 hours should be less than 120. Medication safety in pregnancy: insulin is safe, does not cross the placenta. Metformin crosses the placenta, use with caution. Sulfonylureas are absolutely not used, they cross the placenta. Use benefits are more than risk. Avoid GLP-1 receptor agonist and SGLT2 inhibitors because they promote weight loss. Final goal: healthy mother, healthy baby, optimal glycemic control throughout pregnancy and beyond. Remember, early diagnosis, timely treatment, close monitoring, and postpartum follow-up saves lives. So every pregnant lady who has a family history of type 2 diabetes mellitus, but and as a universal rule, in the second trimester should be screened for type 2 diabetes mellitus, ideally with OGTT. And if she has GDM, then the ideal drug for treatment is insulin. Okay, and if not, alternative with metformin. And the targets are fasting less than 95, 1 hour less than 140, 2 hour less than 120. During labor, she should receive IV regular insulin, and immediately after labor, all the insulin hypoglycemic drugs like insulin or metformin should be discontinued. And these kind of pregnant ladies should be monitored for development of type 2 diabetes mellitus. They should have at least one OGT done between 1 to 3 months. Okay, at the end of uh, the treatment, the goal is to have a healthy mother with healthy baby. So that's all about uh, gestational diabetes mellitus, and we have completed the series of diabetes mellitus very detail and with case scenarios. Thank you.